Great. Okay. Thank you very much. So yes, I'll be talking about also intracranial delivery, but this will be talking about CAR T cells delivered mostly intraventricularly. And like Aleppi mentioned, I've been leading our CAR T cell trials here, which when they started were the first in the world and now are still the highest enrolling. And excited to share some of our experience. Just as a disclosure, last year Seattle Children spun out some of these technologies into a company, and I serve as one of their advisors. So I think a lot of you are probably familiar, but CAR T cells are essentially removing a patient's white blood cells, specifically their T cells in this instant, adding an extracellular antibody domain, an intracellular signaling domain, which you can play with a lot, so that you can ultimately recognize a target. This has been most used for attacking tumors, most famously leukemia, but actually now we have a pediatric lupus trial, which I think is getting fast track approval now, another company developing that for adults. So there's a lot of applications for this technology, but a lot of these technologies before 2016, when I got here, we're using the paradigm that you do a systemic leukapheresis, you engineer the cells ex vivo, you grow them up into the hundreds of millions, and then you infuse them back into the blood, which at least in the case of children and adults with leukemia is exactly where the tumor is and the easiest compartment to access. So all of that would make sense. As it was alluded to in the previous talk, that doesn't always make sense for the CNS. So when they were thinking about what are ways to get CAR T cells into the brain, obviously viability is an issue, other things. So certain catheter systems, certain length of time, other things don't work very well. But what City of Hope was able to design was a system where with a quick thaw and a delivery, you could do, even as an outpatient, intracranial delivery, either intratumoral through a catheter or intraventricular, most often through Omayas, but not particularly novel technology. And that simple route of delivery would actually allow you to give repeated infusions, some of which were very frequent, and they were seeing radiographic responses and tolerability when targeting IL-13 receptor alpha 2 in adults with glioblastoma. So that really inspired me to move towards immunotherapy as so many molecular targeting approaches of tumors were failing. And Seattle Children's was a leader in this and had already developed multiple leukemia trials, including the first published pediatric leukemia experience along with CHOP, showing a great response rates targeting CD19. And then Naveen Pinto and Julie Park and Mike Jensen had also moved to a solid tumor trial. And so when I came, I was tasked with writing and directing our CNS program, which at the time Baylor had a program that was dosing IV, but nobody in the world had an intracranial program at that time. Obviously borrowing a lot from our previous experience, but then also relying a lot on City of Hope and Christine Brown's experience. When we were looking at what antigens to target, it wasn't the exact same list as adults. Obviously, pediatric tumors don't have the same antigen expression as adults. They're, less commonly hypermutant, much fewer alterations. And the list of things we had to target was very different. Some things are similar to some other diseases like HER2, obviously on breast cancer, EGFR on some glioblastoma, and B7H3 was coming out through work of Mark Sudane and others, that this, also known as CD276, was a highly relevant target. So based on some CAR T cells Mike Jensen had already developed in a rank order based on expression of tumors, we planned for 3 initial single antigen targeting trials. And these started in 2018 with Brainchild 1 and Brainchild 2 targeting HER2 and EGFR respectively. And essentially the system was children would come to Seattle, they would enroll, they would get apheresis. That whole process takes about 3 days, and then they would return home. We start CAR T cell manufacturing, which takes about 10 days to manufacture, 14 days of quality testing. And at that time, children would go into an arm with either localized delivery with an Ommaya catheter into the tumor or into the ventricular system. And probably outside of the timing available for this talk, because you have a much different immune compartment of the brain, there's nobody that's been shown, and probably from a toxicity perspective would not even want it, to have persistence of cellular immunotherapy in the brain. You do a repeated infusion strategy. There's some adult trials that just do 1 infusion now, mostly looking at safety, but we felt that to really offer children a chance of benefit, you would need repeated infusions. We also felt that children should be able to get their own dose escalation. So we use a intrapatient dose escalation. And essentially Brainchild 1 and Brainchild 2 were the same system where after cells were manufactured, children would come back to Seattle and then get weekly infusions of intra-Ommaya as an outpatient. I'll show what the procedure looks like in a moment. It's actually, despite at the time nervously sitting outside all of these kids' room and basically be on call 24 hours a day for 3 years. It ended up being less dramatic to do this delivery system than even IV dosing and potentially better toxicity profile. So this was the program that we developed targeting HER2 and EGFR. We published some preliminary results. And really the first thing that we noted was our first 3 patients were subject 1 who got an intratumoral delivery for an extremely large GBM, a patient S2 who got intraventricular dosing for metastatic disease, and then S3 was another intratumoral. And so what we learned from these 3 patients is even though it was the minority of these first 3, which has become very clearly the majority of the now over 150 kids we've enrolled and over 800 doses we've given, is that this is the profile we see most often, which is that with each dose, you get metronomic headaches, sometimes fevers, but otherwise you get very little neurologic toxicity. About 10% of patients have worsening of a baseline symptom that they have, which most often resolves in the same window of the headache, which is starting about 8 to 12 hours after infusion, resolving within 24 to 48 hours. This is what it looks like. To give this, in pediatrics, we don't use Omiyas very often. So actually, when I enrolled our first patient and gave our first dose, I had never interacted with an Omiya before, but now it's our day-to-day. But essentially, you clean the area. We put in a butterfly needle the same way you would to start an IV anywhere else. We take off about 10 cc's of CSF. We thaw the CAR T cells, which have been, instead of one large product like you do for leukemia, are fractionated into individual doses. That's about 2.5 mLs. We infuse it, takes about 3 minutes. We flush it with 2.5 milliliters of preservative-free normal saline. We pull out the needle. The whole thing takes about 4 minutes. That's the intracranial CAR T cell delivery. We do this as an outpatient, and children don't even have to spend the night in the hospital. What the first 2 trials didn't include was children with diffuse intrinsic pontine glioma, which Alippi mentioned is what my lab focuses on and what are most of the patients that I take care of and give guidance kind of nationally and internationally on. So we were enthusiastic to start enrolling them, but waited for this initial experience before we did. For people who don't see these tumors, there's about 400 of these patients a year in the United States. It makes up about 8-10% of pediatric CNS tumors. Unfortunately has a median age of 7 and a median survival of a year. So when you add all this together, it's responsible for about 25,000 years of potential life loss just every year in just the United States. What multiple groups, including Mark Soudane, Robbie Masner at Stanford, Dalia Haidar had showed at St. Jude, B7-H3 is highly expressed on a range of CNS tumors and not on normal CNS, and in particular was the most consistently expressed on DIPG, although GD2, which we don't target as a group, but other teams like Stanford do, it can be more highly expressed. B7-H3 was the most consistently expressed. When we looked in our own models in our lab, these are 4 patients with DIPG who had biopsies here in Seattle, came across town, some biopsy samples here to be grown in mice and in cell culture, and we're able to develop models that we share nationally and internationally. We also found super high B7-H3 expression, as we would expect. And so when we opened Brainchild 3 using this B7-H3 targeting CAR, and I won't get into all of the engineering structure, but a couple cool things about this CAR is it was the first CAR that we put into practice that had the methotrexate resistance gene in it. So during manufacturing, we can introduce methotrexate for purity of the project instead of other sorting mechanisms. And when we looked at this preclinically, without going into all of this because it's published and multiple groups have B7-H3 CAR T cells that are very effective, these are just cell proliferation assays that we do in our lab looking at incucyte. Even at very low effector to tumor ratios, CAR T cells are able to completely wipe out DIPG cells. And for people who work with DIPG or glioblastoma in the lab, basically most of work that you're publishing is 10-day survivals, 15-day survivals, maybe a 20-day survival. CAR T cells are the only thing, granted with lots of limitations in the model system because they're immune incompetent, are the only things that completely eradicate disease. So this is a DIPG model in mice with about 100-day survival. When we give 1 dose of intracranial CAR T cells, we're able to effectively wipe out the tumor in all of the mice and make them long-term survivors out to day 300, their natural life. So while this isn't proof that a single dose, I think, will be curative for anybody, it's a biologic proof of principle of the effectiveness in an in vivo system. And from there, I'll talk specifically about results that were in a Nature Medicine paper that just came out a few weeks ago, because while we have a broader experience across 4 trials now, children with DIPG really sadly have a very specific course. And so it's sometimes easier to draw some conclusions about what their treatment has been like. So when we opened Brainchild 3, which is our B7H3 targeting CAR T-cell trial, we had the same localized arm, we had the same recurrent refractory metastatic arm, but we added a new arm, arm C, for children with DIPG. Again, intraventricular dosing, thinking the lateral ventricle is flushing through the third ventricle and around the pons, so we're getting CAR T-cells relatively locally. The only way to dose directly into the pons, although plenty of sites do it with CED, requires a heated long-term pump system that just is not compatible with CAR T-cell viability. So that's not even a possibility with current technologies, but we were happy with the intraventricular approach and moved forward with that. We had the same enrollment apheresis manufacturing strategy as described before, only instead of dosing weekly with this cohort out of concerns for some increased toxicity. Before this trial opened, there were actually a few immunotherapy trials for DIPG that had closed early due to deaths. So we dosed every other week. In our first group, we did not do an intrapatient dose escalation starting at 10 million cells. But after that, all the other groups had intrapatient dose escalations getting up to 100 million cells. And this is just looking at the eligibility. A couple things notable. A lot of studies for children with DIPG don't allow metastatic disease, don't allow previous reirradiation. Some don't even allow progression. Some don't allow even extent outside of the pons. All of those things really frustrate me as somebody who interacts with a lot of these families. So we tried to make it as easy as possible with relatively loose enrollment criteria. This is just a consort diagram of our trial showing the kids that were in dose regimen 1, 2, 3, and 4, with probably just for the scope of time here, I'll say we were able to get up to the highest planned dose of 100 million cells per dose of repeated dosing. And we were also able to show, besides individual dosing, safety over long terms. One of our patients enrolled when he was 2. He just turned 6 a few days ago, and he's now had 87 intracranial doses over 3 years of CAR T-cell treatment. So besides just showing tolerability of individual dosing, we can do long-term repeated dosing intracranially where kids are still going to school, developing normally. The side effect profile I ran through before, but for more details, you can see the recently published paper that came out. But essentially what we see is, as I mentioned, fever, headache, sometimes nausea and vomiting with the headaches the night of the infusions, usually resolving, about 10% of patients having some type of transient neurologic worsening of a baseline symptom, which often improves on its own after a few days. Unfortunately, we did see one patient with intratumoral hemorrhage in the pons, which was the only DLT we've had across any of our 4 studies. But that patient had the lowest planned dose, had a hemorrhage in her pons 8 days after her infusion, which is atypical for the side effects we normally see, and DIPGs can spontaneously hemorrhage, but we're quite conservative, which I think is the appropriate approach with these types of trials. So we reported it as a DLT, but we have not seen it again. This is just a 6-year-old patient with histone mutant disease who enrolled, had multiple progressions, was on high-dose steroids, and as one imaging example, was able to come off steroids, had improvement in her symptoms, had about an 80% reduction in the overall T signal in her pons, and did well for multiple months, but then unfortunately relapsed in the spine. So showing that that's just another example of, while we have some successes, they're not always sustained, and they're certainly not universal. I think phase 1 trials are really complicated, especially in pediatrics, based on how many things people have done before they get to the study. And there's an enormous problem with an immortalization bias that we have, which we've seen with some recently published studies. So I find it most appropriate just to show swimmers plots where you get to see everything you'd want to know about these patients. But these are children with DIPG stratified by patients who unfortunately enrolled but became too sick to ever receive their CAR T cells. Then a group of patients who had a progression before the start of CAR T-cell therapy. And then below are patients who did not have a progression before they enrolled. And what's notable here for people who are familiar with DIPG is we now have 3 patients who are making it close to 4 years from their diagnosis, when the average survival is 12 months. And before this study, I had personally never taken care of anybody who had survived to 4 years. This is our Kaplan-Meier's, which again, to avoid an immortalization bias, are not from diagnosis. These are from your first CAR T-cell infusion. I'm just showing all patients on the left, and then on the right are patients stratified by if they had a progression or not before their first CAR T-cell. And so while we have a few long-term survivors here, which is extremely atypical, obviously these are phase 1 trials, and while we try to be as forgiving and open as possible with our eligibility criteria, certainly the fact that children have to get on a plane, their families are sophisticated enough to find a phase 1 trial, there's some biases baked in on who we're enrolling. So we're planning a phase 2 to better understand these results. I'll also say that, we're obviously trying to do as many correlatives as we can. We live in a world where previously taking care of children with DIPG, you wouldn't get CSF as staging, you wouldn't collect CSF while they were on any studies. And now, because we have OMIAs in place, we have children with literally liters of CSF that we've banked. And so we're learning all types of new things through simple MSD panels, circulating tumor DNA, exosomes, mass spec. And here's just showing some of the published data, showing a couple cool things that our lab is taking to iterate on. But we see after year infusions clear markers of inflammatory changes. Some of these we think might be stratified with response and not. Stanford just published a really nice paper on their GD2 experience showing that IP10 or CXCL10 might actually be related to going down at the time of progression. We see it going up with a lot of our best responders, and overall, when you look at everyone going up, and that's for people who are not as familiar with immunotherapy, is a T-cell trafficking migration, important chemokine. So a lot of things that are interesting and to build upon from the CSF that we're learning, but the main thing, obviously, we're learning with these phase 1s is tolerability. So across the 3 trials, and a fourth one I'll touch on briefly, where we're using a multi-antigen targeting CAR T-cell targeting 4 antigens, we've been able to show tolerability with over 150 kids enrolled, over 800 doses total. We've now helped places like London, Sydney, St. Jude open their programs, and along with other sites that have pediatric programs now, like City of Hope, Stanford, and Baylor, I think we've shown that intracranial CAR T-cell delivery is safe, it's feasible, and this is really the foundation of what we can do. And we now have, what I think will probably be decades of work in optimizing their trafficking, optimizing their effector function, optimizing what other payloads, and then how they combine with other agents. Starting with multi-antigen targeting, just briefly, so we opened a Brainchild 4, which we always wanted to move towards multi-antigen targeting, and we are targeting EGFR, B7-H3, HER2 like we did before. Mike Jensen, who led our program, was previously familiar with IL-13 receptor alpha-2, the CAR he had helped develop at City of Hope, and so we included that, and we have children enrolling that now, which I won't touch on today for time. Combinatorially, there's some oncoceutics drugs, ONC201, ONC206, which in my hands don't have much of a benefit individually, and I think have published some data that suffers from that immortalization bias that I determined before, but are certainly well-tolerating and promising for what their combinatorial strategies can be. And so we've seen when we combine ONC206, which is what we use in the lab because we don't find ONC201 to be effective, ONC206 mixed with CAR T cells can have some benefit, but again, this is just in a minority of mice, and so has a long way to go. And other things like enhanced CAR T cell migration, as I mentioned, things like CXCL10 or IP10 are elevated, which we published and seen. The receptor via CXCR3, besides building in surface antigen targeting through antibody domains on CAR T cells, you can do lots of other different things. So we overexpress CXCR3, the receptor for CXCL10, and I won't go through all the in vitro data, but we were able to show that these CAR T cells traffic much better when you challenge them through migration transwell assays. They migrate better. So when you overexpress receptors for chemokines, even if those receptors are already expressed on T cells, if you super express them, then you can get better migration. And when we do this in animal models of DIPG, when we give IV non-targeting CAR T cells, IV B7-H3 CAR T cells, IV enhanced migration CAR T cells, they never get into the brain or really have a benefit. When we give non-transduced intracranial CAR T cells, also no benefit. When we do our standard B7-H3 CAR T cells in this hyper-aggressive model, definitely a survival benefit, but only one mouse long-term survivor. When we do B7-H3 CAR T cells that also have enhanced migration capacity, we get much better overall in vivo data. So in summary, I would say that we feel that B7-H3 CAR T cells are tolerable, that it can be managed as an outpatient repeatedly dosed intracranial procedure. I mentioned how many children we've enrolled and doses we've given now. We'll be opening a phase 2 later this year. and then a series of other phase ones, and then also working collaboratively with other pediatric sites across the country and across the world. Actually, we just had somebody from the Sydney CAR-T cell program out here and are planning to work together. CAR-T cells, I think especially B7H3 mixed with small molecules, have a promising future. In my biased hands, much more promising than small molecule plus small molecule. And then there's other modifications you can make, like enhanced migration. I already talked about the future steps, just I think for getting us on time, I think I'll skip that and just say our team here is gigantic. Julie Park, who now is running St. Jude's oncology division and doing expert work there, and we miss her a lot, but was my main mentor here in writing and directing these trials. Mike Jensen, who is the architect of the CAR-T cell engineering. Sarah Leary, who runs our neuro-oncology program. Rebecca Ronsley, who's taken over as the PI and the study chair of our trials as I've transitioned to more lab work. And then Allison Thompson, our coordinator, who interacts with so many of these patients. And then just for lab work that was related to me, these are funding sources and folks that are in our lab. So I think I'll stop there, and thank you everybody for your time and your attention and the invitation to speak here today.
Thank you, Dr. Vitanza. What a phenomenal talk and what exciting data. If anybody has questions, you can put them in the chat. I didn't see any as of a second ago. I have one question. We had, in the adult space, we had a New England Journal paper, I think last year, with 3 patients with really striking radiographic data, but very rapid relapse. And so what I was really impressed with your data was, as you pointed out, the durable, the duration of response. So I was just wondering if you could comment on that. Is there any difference between kids? Is it just their immune systems are better, or do the CAR-Ts survive longer?
No, I know Stephen Bagley and Brian Cho, who ran the Boston and Penn papers that came out pretty close together. They're both expert groups doing really expert work. I think they still are using a single dose paradigm. We know, I think irrespective of what you're targeting, T cells are not happy in the brain. Evolution has made sure that you don't get immune insults into the brain. So you also basically don't get immune cells in the brain, except for things like microglia that have other roles like neuronal repair and things. But T cells are just not really present there. And even when they're in the tumor, they're relatively low levels. They're nowhere else. They're not happy. So what I think is the main obstacle to them getting durable responses is just needing to do repeat doses. They do one dose. We know CAR T cells live for, depending on your CAR T cell, 7 to 21 days in the brain. The numbers get pretty low pretty quick. Okay, maybe they're all in the tumor working, but we don't see them in the CSF. So without overestimating what our technologies can do, I think they're not there pretty quickly. So that's why we replenish, basically. Obviously, you don't need to do this in the blood, so it's a different paradigm, but I think that they will benefit once they start doing repeated dosing.
Thank you very much, and thank you for joining us. Okay, I'd like to introduce